Hello, this is Dr. Alexander Wiseman from the University of Colorado School of Medicine in Aurora, Colorado. Welcome to this educational activity on patient views and attitudes about life after kidney transplantation and best practices for patient-focused care.
The following audio is from a two-part presentation with Dr. Alexander Wiseman. This audio is part of a certified educational activity titled Improving Long-Term Outcomes After Renal Transplantation: The Importance of Patient-Focused Care. To access the entire activity and complete the post-test, please go online to www.peerviewpress.com/RDY. A printable transcript, slides, practice aids, and other features are also available.
In the United States, there's a growing number of individuals living with a kidney transplant due to three general factors. Number one, a growing ESRD population. Number two, better survival rates among transplant recipients. And three, advances in surgery and medicine that make transplant an increasingly viable option. Community nephrologists and other healthcare professionals have now become more vital in the management of kidney transplant recipients. However, management of these patients is time-consuming, requires a great deal of communication and coordination of care, and is challenging for a number of reasons. These include management of immunosuppressive therapy, management of comorbidities that often worsen after transplant, patient adherence issues, and finally, monitoring and screening for complications that are common after transplant: rejection, infection, and malignancy. To address these gaps between understanding of what renal transplant recipients are going through and healthcare professionals' care of these patients, and to form the content of this activity, a survey was deployed by the American Association of Kidney Patients, AAKP. These responses were received by 128 kidney transplant recipients in the United States who are receiving immunosuppressive therapy to prevent rejection. 54% had received a deceased donor transplant, while 46% had received a living donor transplant. Now, these statistics are a bit different from our 2014 statistics from the Scientific Registry for Transplant Recipients, SRTR, in which 2/3 of our patients are receiving deceased donor transplants, while 1/3 are receiving living donor transplants. These discrepancies within the survey and the national population are probably due to differences in those who actually can respond to a survey versus the general population. They have computer access, and they're participants in a patient organization. So one aspect that the survey addressed was immunosuppression used after transplantation. This is clearly the most important component in the management of a kidney transplant patient. Clinicians must identify an effective drug regimen that achieves adequate immunosuppression but minimizes the short-term and long-term adverse events. So what are clinicians in the United States actually prescribing for their patients? When we look at the most recent data available from our registry analyses, we can see that the following trends have occurred. Most immunosuppression protocols have really not changed markedly since 2008. Over the years, there's been an increasing trend toward use of T-cell depleting antibody. Tacrolimus is the calcineurin inhibitor, and mycophenolate rather than a mammalian target of rapamycin inhibitor, or mTOR inhibitor. How does this compare to the patients in our survey? When asked about their current treatment, these findings, as you can see on the slide, were fairly consistent with registry data. 70% were using tacrolimus twice daily, 67%, or 2/3, were on a prednisone-based regimen. One comment that I would like to make is that 5% were on a tacrolimus once daily regimen, and we can see that there's going to be a difference as we look at prior treatments in the next slide. When asked what patients had been taking previously that had been changed or discontinued, and remembering that these patients came largely over a broad spectrum of transplant eras, including a substantial number over 10 years post-transplant, you can see a little bit different numbers. I think that the overutilization of cyclosporin and tacrolimus once daily is probably likely due to era effect in terms of how long ago patients were on these medications, and also due to potentially the fact that these patients, again, as a part of a survey and a part of a patient group, may have been involved in clinical trials. Suggesting that basically these changes in medications are really not an infrequent occurrence, and we have to be familiar with how to use these medications and be nimble in being able to transition from one medication to another according to side effect profiles. So now we know what types of immunosuppressant therapy our patients are receiving. Let's take a look at the benefits and limitations of the current options to see why one agent may be preferred over another. So starting with the calcineurin inhibitors, tacrolimus and cyclosporin, as we've shown already, tacrolimus has been more frequently prescribed, particularly in the last few years. This is probably due to the fact that it's associated with lower acute rejection rates, similar costs to cyclosporin. And with tacrolimus, there is a higher exposure of mycophenolate because unlike with cyclosporin, tacrolimus does not alter mycophenolate drug exposure. In terms of adverse events, one also has to keep in mind that every medication has different side effect profiles, and tacrolimus is associated with a higher incidence of post-transplant diabetes that appears to be dose-related, but in general has been better tolerated and preferred by patients compared to cyclosporin for various cosmetic and other effects. There are longer-acting once-daily tacrolimus formulations, as we've mentioned, and they may confer potential benefit by minimizing variability in drug exposure. They might simplify immunosuppression regimens, and thus they may improve medication adherence. Regarding the long-acting versus BID tacrolimus preparations, they have comparable efficacy and safety profiles, and this has been shown after 4 years of follow-up in a very pivotal clinical trial that led to FDA approval in our country. But again, with higher incidence of new-onset diabetes after transplant and superior renal function compared to patients receiving cyclosporin. Turning to the antimetabolites, azathioprine and mycophenolate appear to be similar in terms of long-term allograft survival rates, but despite increased cost, mycophenolate preparations, or MMF, generally is preferred because of several initial pivotal studies that found lower acute rejection rates with mycophenolate. Thus, while 90% or greater of transplant centers actually use mycophenolate as the antimetabolite, there are some circumstances in which other agents such as azathioprine should be used. For example, in men planning to become fathers and in women attempting pregnancy, since MMF is teratogenic and is contraindicated in pregnancy. Gastrointestinal side effects are more common with mycophenolate, and perhaps more so with mycophenolate mofetil than mycophenolate sodium or enteric-coated formulations. If patients don't tolerate the enteric-coated formulation, the dose can be lowered, or we can consider switching to azathioprine in a stable patient scenario. Regarding the use of corticosteroids, there's really no consensus on the optimal dose or tapering schedule of steroids following renal transplantation. A very well-done 2008 study that was randomized, double-blind, multi-center trial compared early corticosteroid withdrawal, CSWD, with chronic low-dose corticosteroid therapy with an average of 5 milligrams a day from 6 months of transplant and beyond. And interestingly, comparing these two approaches to corticosteroid use, there were very few differences. Lipids were slightly better in the corticosteroid withdrawal arm, but there was no difference in cardiovascular risk, surprisingly no difference in weight gain, no difference in new onset diabetes overall, no difference in kidney function, and there actually was increased risk of immunologic injury in a corticosteroid withdrawal protocol. Higher rates of acute rejection were noted, and in those patients with acute rejection, there was histologic evidence of worse chronic graft injury. Turning to mTOR inhibitors, there are 2 FDA-approved mTOR inhibitors available for use, sirolimus and everolimus. These have been studied either as a substitute for calcineurin inhibitors or as a substitute for the antimetabolites. Potential advantages of mTORs include the avoidance of CNI-related side effects such as nephrotoxicity, neurotoxicity, a lower risk of developing CMV, and a lower risk of skin cancer, but with the attendant risks of potentially poor wound healing, hyperlipidemia, an increased risk of post-transplant diabetes, and proteinuria. One such study evaluated the use of a transition from a cyclosporin-based regimen to an mTOR-based regimen using everolimus, the ZEUS trial. 300 de novo kidney transplant recipients were randomized to continue cyclosporin or convert to everolimus at 4.5 months post-transplant. Interestingly, at 5 years, the adjusted estimated GFR was higher with everolimus-based therapy. However, the cumulative incidence of biopsy-proven acute rejection after randomization was higher also in the everolimus arm. So really one has to look at these data and say that with any change, one hopes that the benefit outweighs the risk. Another agent that's been studied as an alternative to calcineurin inhibitors is belatacept. This is a selective T-cell co-stimulation blocker that's given intravenously on a monthly basis after a period of stability post-transplant. The BENEFIT and BENEFIT-EXT trial showed substantially better glomerular filtration rates compared to cyclosporin, with actually a reduced risk of death and graft loss in the non-expanded criteria donor recipient population. As you can see on the slide, you can see a substantial improvement in GFR even at the 7-year point in those patients that were followed. There is a boxed warning for use of belatacept due to the fact that there is a higher incidence of post-transplant lymphoproliferative disease. So now that we've reviewed our options for immunosuppressive therapy, how should we optimize the use of these agents in individual kidney transplant recipients? I think we need to take into consideration why grafts are lost and how this has changed. Our paradigms have changed over the course of the last decade or so. In the past, our consideration has been that this has been primarily a T-cell mediated process, and all of our immunosuppressive agents have really been changed in relation to T-cell mediated inhibition. Our present understanding of why grafts are lost is that we're probably really facing an insufficient control of the humoral arm of the recipient's immune system by our current immunosuppressive regimens. Specifically, formation of donor-specific antibodies and the resulting injury now supersedes the historical dogma that allograft losses were caused by calcineurin inhibitor toxicity or chronic allograft nephropathy not otherwise specified. Donor-specific antibodies can emerge at any time after transplant, and they probably occur in about 20 to 30% of transplant patients based upon recent data. These de novo donor-specific antibodies, or DSAs, are mainly class 2 and are associated with a worse prognosis than our DSAs to class 1 HLA molecules. DSAs are responsible for a very complex array of types of antibody-mediated injury, including a particularly ominous form of chronic rejection that is termed transplant glomerulopathy. There are a number of factors that impact de novo DSA formation after kidney transplantation. One can notice that viral infections can contribute, autoimmunity such as AT1 receptor antibodies, transplant nephrectomy, as well as mismatching of HLA, including HLA-DQ and DR. But I think the primary focus and the primary attention should be really drawn to two primary factors that lead to de novo DSA, and that's inadequate immunosuppression overall and medication non-adherence. Once DSAs develop, unfortunately they develop ongoing injury to the allograft, and it limits the half-life of the graft and results in a sensitized patient who will be very difficult to retransplant. So now that we know that the late failure of kidney transplant remains an important clinical problem, and of course we want to prevent this from happening, we probably should revisit our patient survey to look at post-transplant concerns, given the fact that non-adherence or inadequate immunosuppression may be a primary driving force. Respondents were asked to rate their level of fear and anxiety of rejecting their kidney transplant as very low to very high. And you can see a fairly broad bell-shaped curve. We'll look at data examining this relationship between graft failure after transplant and medication non-adherence. But first, let's take a poll to see if you think your patients are taking their medication as prescribed. So here are the survey results. In the past 3 months, respondents reported having forgotten to take their medications only rarely, 32% of the time, sometimes 5% of the time, and never 63% of the time. Patients stop taking their medication because they're feeling worse very rarely, perhaps 1% of the time. Again, this may not reflect the general patient population, as these patients are clearly on medications, have undergone medication transitions, and perhaps have had conversations with their care providers to better address their adverse events. There were about a third of patients that missed medications, either sometimes or rarely. We really should be addressing this issue of non-adherence, whether it's one medication absence or whether it's a substantial frequency of missing medications. How can we truly measure adherence in our patient population? There are clearly some objective measures that may be very time-consuming, which includes direct observation that medication was consumed, serum drug levels, biological markers, tracers, electronic pill monitoring, pill counts, refill records from the pharmacies, and subjective measures, simply asking the patients, as we did in this survey. There's clearly no perfect measure of adherence in clinical practice, and we really need to incorporate more than one approach if we're going to identify non-adherence in our patient population. Nevins et al. Prospectively identified medication adherence patterns in 195 kidney transplant recipients using electronic medication monitors. The drugs that were monitored were mycophenolate mofetil, sirolimus, or azathioprine. And of these 195 patients, 44 patients, or 22.6%, actually decreased adherence by 7% or more at month 2 post-transplant. That's the equivalent of saying that they missed a dose a week, 2 months post-transplant. So the period, the time that we think our patients are getting the most education and maybe the most adherent to their medications, they were still missing their medications. This was associated ultimately with more frequent and earlier acute rejection and more frequent and earlier death-censored graft loss. And thus these data highlight that medication non-adherence does appear early post-transplant. And this pattern of early declining adherence is associated with significantly poorer late allograft outcomes. The leading factor in our survey respondents was a fear of adverse events such as bone disease, hair loss, and cancer. They really didn't notice a significant concern or problems in terms of adherence when discussing difficulties to pay for therapy, inability to tolerate therapy, forgetting to refill prescriptions, or complexity of treatment regimens. And again, one should keep in mind that these findings are from survey respondents who are clearly very active in their care, responding to a survey, part of a patient care group, and that this could look entirely different for a patient population in your clinic in whom the inability to fill prescriptions or difficulty to access healthcare provider care and pharmacy could be major factors. So using an open text field, patients were also asked to indicate whether there are other barriers that they felt were significant. Issues such as forgetting a dose, memory, fitting it into their schedule, busy work-home life, routine schedule changes, and travel outside of routine were much more obvious within this cohort than perhaps another cohort. So reflecting on the fact that adverse events are traditionally a very significant barrier to adherence, we asked patients about specific immunosuppressive therapy-related side effects that concern them the most. And as you can see on the slide, the features that concern them the most include the risk of cancer, the risk of bone disease and joint pain, risk of infections, fatigue, and then a number of cosmetic issues, including weight gain, skin thinning, hand tremor, puffy face, swollen gums. Of course, gastrointestinal side effects are a continued issue, as are psychological and neurologic effects, such as aggression, moodiness, and memory loss. We need to be aware of the interventions that have been demonstrated to be successful in increasing adherence. Communication and consultation, patient education and resources, practical devices and tools, and healthcare systems have all been identified as domains within a meta-analysis published by Tong et al. Simplified dosing could actually make a difference, particularly in the patient population that we have surveyed. So the studies in the literature does support a simplified dosing regimen. For example, once daily dosing of tacrolimus-based products have been, generally speaking, found to be more effective in improving adherence, although there have been some studies that have also shown no effect. So considering the importance of effective communication, we asked survey participants about interactions with their healthcare provider regarding the selection of immunosuppressive therapy. If there's any issues that our survey respondents disagreed to, was that the provider asked about goals, needs, and preferences. Patients did note that they received educational materials regarding side effects. They were offered easy-to-understand information regarding the treatment options, and adherence was focused upon within a provider-patient discussion. Patients should be aware of the importance of prescriptions and be advised to ask for further explanations if they have doubts. They should have the telephone and email details of members of the transplant team to freely communicate any problem that may arise. They should be advised to use a pill box, a daily checklist of drugs, a reminder system such as a beeping watch. They should communicate about any transplant-related adverse event, especially before stopping a suspected drug, and communicate in due time if they do have it to change the date, time of a scheduled visit. To conclude, transplantation has really made a considerable difference in the lives of many patients, but feedback from patients indicates that although having a transplant is overwhelmingly positive, having to take medications indefinitely is one of the biggest challenges. An ideal scenario would be to have to take no medications following a transplant, but a compromise would be to take a minimal number of medications with minimal restrictions and in a simple regimen as possible. Although there's considerable research going on to fine-tune the management of the immune response to the kidney transplant, to date there's no universal regimen that enables patients to remain free of immunosuppressant medications. Considering this, clinicians require a broad knowledge and appropriate skills in the management of immunosuppression in order to enhance adherence and minimize side effects in the individual patient. And we can do this by tailoring the medication according to lifestyle, comorbidities, and to the immune status of the individual. It's clear that patient engagement is needed to achieve optimal adherence and ultimately maximize graft survival. This is not a one-size-fits-all approach, and in most scenarios, this will require a skill mix beyond the reach of a nurse, pharmacist, physician, or surgeon, and requires a multidisciplinary approach.
Thank you for listening to this activity. To view the rest of the CME-CE activity, download materials, and complete the post-test for instant credit, please go online to www.peerviewpress.com/RDY. This activity is supported by educational grants from Astellas and Novartis Pharmaceuticals Corporation.